Hi, David Rosenberg here for the Psychopharmacology Institute. I'm professor and chair of the Department of Psychiatry and Behavioral Neurosciences at Wayne State University, and have also served as chief of child psychiatry at the Children's Hospital of Michigan. I first authored the first textbook on pediatric psychopharmacology, which is now in its third edition. So child and adolescent psychopharmacology is something I'm very passionate about. At present, there are only two FDA-approved antidepressants for youth with major depressive disorder, fluoxetine and escitalopram, and only fluoxetine is FDA-approved in pre-adolescents. So the need for additional medication options in youth with depression is clear. High placebo response rates in depressed youth has further complicated this issue and made it challenging to discriminate medication versus placebo differences. But there's no question for clinicians in the trenches treating depressed youth, there's a huge need. In this CAP, or Child and Adolescent Psychiatry Smart Take, we'll look at a 6-week randomized double-blind placebo-controlled trial of duloxetine in 148 children and adolescents 9 to 17 years with major depressive disorder in Japan, which was followed by a longer-term open-label extension trial of about 1 year to evaluate longer-term safety of duloxetine. And this was a study conducted at 36 medical institutions in Japan. Consistent with studies of duloxetine in children and adolescents with major depressive disorder in youth in the United States, absolutely no significant difference was found for duloxetine versus placebo in children and adolescents with major depressive disorder in Japan. And because of this, the open-label extension trial was terminated early. Like with many other industry-supported studies, the placebo response rate was also high in this trial. Overall, duloxetine was well tolerated with no new safety signals noted. What's the bottom line? Duloxetine is not ready for primetime use in children and adolescents with major depressive disorder. Frankly, it's not surprising that duloxetine didn't separate from placebo in depressed youth in Japan. This is consistent with prior controlled studies of duloxetine in major depressive disorder in youth in the United States, so duloxetine can't be recommended for the treatment of major depressive disorder in children and adolescents at this time. The bottom line, again, is that the SSRIs remain the safest and most effective treatment of choice in terms of medication in depressed youth, and the safety profile for the non-selective serotonin reuptake inhibitors like duloxetine is not as good, and the evidence for its efficacy in both depression and anxiety in youth is much more mixed. So more often than not, the best practice and the evidence-based best practice is to go with an SSRI, particularly fluoxetine or escitalopram, when medication is indicated for children and adolescents with depression. These negative findings in so many antidepressants tested in youth that have been successful and effective in adults with major depressive disorder really underscore the importance of brain and pharmacogenetic research to identify predictors and biomarkers of treatment response or lack thereof. So the quest for novel approaches to better treat child and adolescent depression is vital, has to go on, and we still don't fully understand what are the developmental, genetic, or other factors that account for the age switch from adolescence to adulthood, where there is this broader and more significant response to non-SSRIs which occurs. So at present, duloxetine not recommended as a treatment for child and adolescent depression.